We are going to look at showcase one of the some of the findings from a study called the CHAMS. Next slide. This is child health and mortality prevention surveillance. Next slide, please. Being one of our studies which focuses on the theme of today, and using one of the mandates lines of CAMRI, collaborating with international partners and local partners in conducting research and capacity building. CHAMS is a study which tracks the definitive causes of child mortality using a multi-country common protocol represented in regions with the highest burden of disease, that's Asia and Africa. We use more sensitive approach to determine cause of death. We are aware that limitations on from the verbal autopsy use as a method to determine cause of death has not been effective in helping us to understand the trajectory and profile of a more comprehensive causes of death. So using minimal invasive tissue sampling technique, which involves the process of taking tissue samples from various organs when a child dies, provides us with the opportunity to produce and disseminate high quality data that can actually be used to inform policy and public health actions, which actually can drive the next generation of interventions that the world needs, especially in high disease burden regions in Asia and Africa, where we know over 80% of deaths occur.
Have you ever thought about what it means when a mother goes to have a baby and they don't come back home? What does that mean to the family? The psychological effect, the economic effect, the social effect. Or a mother goes to have a baby and they come back home without a baby. What does that mean? So this has motivated us as AMREF to really go deeply to look at what does the data direct us to do. So I'll start off with a graph that most of you have seen before. If you look at this graph, shows maternal mortality ratio trends in this country, and you'll see there was a significant reduction from 2008 to 2014. But from 2014 to 2022, the graph has really flattened. There's improvement, but very, very minimal. We have learned as AMREF, and this has shaped the way we look at these health facilities. And our question is, are there health facilities that are doing better? And if they're doing better, is there something different beyond what we have always programmed around, the commodities, the RH, the workload things? Is there something that goes beyond in these health facilities? So we did an assessment of exemplar health facilities, and this narrowed down to 4 health facilities. And these are health facilities that are having a lot of deliveries. So many deliveries are happening within these health facilities. But if you look at their health facility maternal mortality ratio, it's amongst the lowest. Pumwani, so many deliveries, very low deaths. If you look at Kiambu County Referral, it was even referred to yesterday, doing very well. When it comes to faith-based, we looked at this facility called St. Clair Kaplong, also doing very well. So went and looked at, do they have something beyond what this other facility is not doing that we can learn from, and develop a change model that maybe can focus into other facilities to really make improvement.
When we say our mortality rate, maternal mortality rate is 355 per 100,000, how many mothers do you think we have saved in that ratio? Any idea? Like in that ratio, do we say we have saved 100,000 minus 355? Or what ratio have we saved? Have you ever thought about it? But maybe we don't have an answer in the room, but let me give an answer. The answer is in the history. When you go to pre-modern medicine and you start looking at the maternal mortality rates that were there in pre-modern medicine, you realize that in pre-modern medicine, their mortality rates in the 1700s, 1600s, 1700s were around 8 to 13 per 1,000 life births. That means the mortality rate to almost how many years ago? 300 years ago was around 800, now using our current 100,000, around 800 to 1,300 mothers dying. That is 300 years ago. So that means with all that we are doing, with a mortality rate of 355, we are saving slightly around 1,000 mothers in their 100,000 live births, which means 99,000 mothers will deliver normally without our intervention.
Before even these things are elevated or are scaled up, already we have a medical officer being part of the team handling the department. The other thing that's changed is the continuous medical education that previously used to be done monthly. Currently we do weekly departmental, apart from the hospital CMEs, we have departmental CMEs we usually do them every Wednesday. And during those CMEs, short topics are done, simulations, and sometimes even drills on how to manage the common conditions that lead to maternal mortality and also neonatal. So things like neonatal resuscitation, managing PPH, eclampsia, and such.
Our maternal mortality journey has not been one of the best. At some point, we were more than 788 per 100,000. We moved to 583 per 100,000, 516 per 100,000, that was shown here. And that one put us number 6 among the counties with the highest maternal mortality. And I'm happy to present today that today we are seated here, the 97th day with 0 maternal mortality. How did this journey start? And you've asked about leadership. Leadership, you might wonder why leadership has been put as one of the building blocks in the WHO health systems. I'm a believer of, you might have all the building blocks, but if leadership is not there, then you might not make it.
How do we work to make sure there's a pathway to scale for this to happen in more and more counties?
We know that there is this current funding shifts and dynamics. It definitely has impacts on us. Have we even had some discussions on how we see this impacting us and what would be some of the models that we see in the future, so that just like you've been proactive with the MPDSR audits, because you know you cannot accept any death, how is it that we want to continue anticipating some scenarios in the future that can get us into 0?
We are doing what we call linking ECHs to facility electronic medical record here in Homa Bay, where the ECHs talks to whoever is in the facility. So the MOH 100, when a CHP clicks and say, I have a mother who is hypertensive, I'm referring, then the dashboard the other side blinks that there's somebody coming who is hypertensive at this blood pressure. And if that facility do not see the patient, then they call back. There's a feedback loop back to the chair and to the CHP again that we've waited for 2 hours, but we've not seen her. So the CHP looks for her again, either she's gone to another facility or not. That is part of extension of the facility-wide electronic medical record.
As I share a few key highlights from the discussion, I just want to pick it from where Dr. Meshach and the Cambridge guy, the question that they asked about sustainability, about the donor funding shrinking, and the change model that Dr. Meshach mentioned. I think they are all aligning in terms of we have learned that there are counties in Kenya with the same challenges, similar issues, but they are doing well. That means there is something that can be done. Change, we can get change. So it's important that we pick a few things from what we have learned from the panelists and build it further to be able to reach the entire country with some of these good innovations or exemplars. Then secondly, on the issue of resources, we have realized from the sharing from the panelists that most of the things that they have highlighted are basically things that can be done even without enormous resources.